CSI Pharmacy once again for providing lunch for us. We appreciate it very much. Thank you, Jamie. And as you're finishing your lunch, I'm going to let Rebecca introduce our next speaker. And I also want to say this as a caveat, which we say every meeting, that if you hear suggestions on medication or how you're going to treat MG, they're just suggestions, even coming from us, that we do not give medical advice, and we always will tell you to talk to your doctor before trying to change anything. So without further ado, Rebecca Dorr.
Oh, come on, guys. So I'm very excited to introduce to you someone who's very special to me. He has been an invaluable resource for me as I've tried to help myasthenics, especially in the realm of IVIG. It's such a commonly used drug, and I think it's a very misunderstood drug. And I think a lot of doctors misunderstand it as well, not out of intention. I think it's just something they don't use enough. So I'm very, very excited to introduce James Sheets to you. I hope you give him a warm round of applause.
Thank you, Rebecca, for that very warm welcome. So I'm glad you guys all enjoyed lunch. I just hope that my talk's not so boring that it puts you to sleep afterwards. So I'll try to make it as exciting as possible. But I should get pretty excited. I do love this topic, and that's for sure. Thank you to Rebecca and David. I opened a pharmacy called CSI Pharmacy about 5 years ago that specializes in just IVIG, or an immunoglobulin therapy. It's about 80% of what we do. So over that time, we've grown quite a bit, but about 2 years ago, I also do all the pharmacy social media stuff. About 2 years ago, I was listening to a speaker and they said, hey, you've got to have your company on Twitter. You know, and I'm like, okay, I'll see if I can go figure that out, because I can't really seem to figure out LinkedIn. I'm good with Facebook, that would make sense. Certainly not Instagram, but I thought, well, I'll try to figure out this Twitter. And created a little page. It was really easy, and found out it's a great resource. I started looking for things on IVIG and information on some of the rare diseases that we treat, one of those being MG. And I came across this at Rebecca Dorr. And I had no idea who she was, but she was sharing lots of wonderful information that I was then taking and sending to our nurses, like, hey, this may be something our patients can benefit from. Hey, did you realize this? And that's been true, really, for all sorts of rare diseases, that personally I feel like we've learned more from patient groups like these, certainly, than what we ever bring here. Because you guys, you're in a position, as Tammy was even discussing earlier, where it's a rare disease that you can't just go to every physician and then know what you're able to learn yourself. So very important that you become knowledgeable in it. But I came across this Rebecca Dorr, and then our vice president of the company for patient advocacy, her name's Michelle Vogel. She's been here to speak before, and she lives in Jacksonville, Florida, and she set up a meeting for me. And so I live in Texas, I came in from Texas, and I'm like, okay, well, who is it we're meeting? You're gonna love this girl, you're gonna love her. It's her and her father. They're really just passionate about what you do, and I promise you're gonna love this meeting. It's a lady named Rebecca Dorr. And I thought, what, are you kidding me? I was like, I found this lady on Twitter, and I don't know her from, Eve. And, so I think I really kind of felt like it was providential and something that we were meant to meet. And we had a dinner together, which was our first introduction. And then from that point on, I just fell in love with Rebecca and David and what they're doing. You can't fake true passion. And it just comes from her in all sorts of ways, and you just leave her presence feeling like, I want to be a part of this. Can I be a part of this? Which I think is terrific leadership on her part. And as I continue to work with her, just more and more amazed at the work you do. This group here is incredible. So like I said, I'm really honored to be here to speak to you, and hopefully I can share something of value. To say something about Tammy and Andy's talk, if you are going through a difficult season, I would definitely encourage reaching out to them or to counseling. On a personal note, and I don't mind sharing this, 5 years ago, I had my own difficult, just right before the pharmacy was started, in fact, I had my own difficult season. Really struggling with my feelings and emotions and depression, and went through a very hard time in my life. And it's not medications that brought me out of it, it was counseling. And so I have a heart for counseling. My counselor was able to teach me how to get away from that stinking thinking, is what we call the bad thinking, and how to reframe things. And it made a tremendous difference for me and my family. So definitely value what counseling brings. And I mean this honestly, I wouldn't be where I was now without that resource. So it was also a good little refresher for me to oh yeah, that's right, I need to be reframing these thoughts. So I really appreciate you guys sharing that. Great group today, so a big turnout. So I've done about, I guess, 12 to 15 of these talks like this to rare disease groups over the last 2 or 3 years, and this is a big turnout. If you add in, I know we're having technical difficulties, but if you add in the people who will be watching from home later, we welcome you too. So glad that you're able to at least join us virtually, and hope you get something out of the topic as well. So to introduce myself, my name is James Sheets. I'm a pharmacist. I have a large family, his, hers, and ours. We have the blended family, and if you've ever done that, you're in my prayers, because I understand firsthand how difficult it is to blend a family. But we have a total of 6 kids together. One of them, our youngest, he's our bonding child. He's here with us, with his mom, and they're at Disney today. So I'm going to join them a little bit later and look forward to that. But I also have 4 grandchildren. 2 of them and their mom live right next door to us, and I wouldn't trade anything for them 2 babies, or all 4 of them. The twins, we actually have a couple set of twins that live close to us, and they're near and dear to my heart too. So come from a big family. Have been interested in neurology really ever since pharmacy school. I kind of had my own little experience with something called Bell's palsy. I had no idea what it was, and went in and I had facial paralysis on one side when I was in pharmacy school. I was stressed out studying and had not slept in 3 days. Contributed to me, I think, developing that. But fortunately I got the right care and it got better, and I only lost a little bit of function. But it spurred in me really interest in neurology from very early in my career. And almost immediately I went into the home infusion industry, right? So doing IV drugs at home. This is back in 2001, right after I graduated in 2000. And we're doing things like IV antibiotics, nutrition, and create these clinical programs around that to help improve the lives of patients. And as I was working in that field, I came across a neurologist in my local hometown who sent us our first group of autoimmune patients, and for IVIG. So we were familiar with doing IVIG in patients with primary immune deficiency, which is kind of what it was developed for, but this was patients with CIDP, which many of you maybe have heard of. It's another autoimmune disorder that the antibodies actually attack the nerve, and started working with that group of patients. And had that pharmacy. We really ended up with about 10 patients or so we were treating on a regular basis until in 2005, or actually 2011, we left that business, and then 2 years later I started CSI Pharmacy. When we started with the idea we'll specialize in this home in this IVIG, or immune globulin therapy. And so I got to pick my name for this company, and I was trying to think what is something people could remember, right? And I knew I wanted specialty infusions in there because it's, specialty pharmacy's kind of been the word of the day for this type of therapy. And I'm usually not very creative, but I really like our logo. So like one night in the middle of the night, I woke up and I'd been thinking on it for a few days. I'm like, I got it. We're going to call it Clinical Specialty Infusions, or CSI pharmacy, and people will think crime scene investigation, right? And you won't forget that, you know, so we'll have a name that people remember. And as I started developing the logo, I'm like, we'll get a little thumbprint and magnifying glass, you know, like you would expect crime scene investigators to have. And so that's what, through the help of some artists, we ended up developing that. And inside the thumbprint, it says, individualized therapies designed to be as unique as you. And that's our company motto. And what we mean by that is, especially in this group of rare disease patients, more than anywhere, in my opinion, everybody is a little bit different. And there's no such thing as really as cookie cutter medicine for people with MG and people with some of these other rare diseases, autoimmune disorders as well. What works for one may not work for another. Somebody may do great on a particular brand of IVIG and someone else just can't tolerate it whatsoever. Different side effects may occur, and there's different ways of managing those side effects. Well, our company's mission is to individualize it to the individual patient, or to tailor it for each patient's needs. So getting the right brand of IVIG, giving it at the right rate, not too fast, making sure that pre-medications, if they're needed, that the right ones are selected. And we do all this by really being the eyes and ears for your physician. You know, so the physician says, I want my patient on immune globulin therapy. They send us an order, and from there starts a process where we try to individualize that so it's the right therapy designed for you. So the meeting topics for today is going to be IVIG. 101 is what we call it, but basically I'm just going to tell you what it is and how it works. You know, how does it work in MG, and how's it dosed, and what side effects can you expect? I'm going to try to keep it as short as possible so you guys, again, do not fall asleep after eating that lunch. But also talk a little bit about some new therapeutic options. One of them is the emerging role now of subcutaneous IG. Okay, so I think that's being studied right now in MG. Hizentra is open label trial. It's already been looked at in the past. It is effective. And I think we'll see a lot more of that therapy as time progresses. And also Solaris, which is, I think it's realized was misspelled. So it always it's not a good time to catch it. But and then a little bit about insurance denials. Before I get started on that, how many people here have actually either had immune globulin therapy before or are currently on it? Can you raise your hands? Okay, so a good group of people. And out of this group, how many of you had it in the home versus, how many had it in the home? Almost half, you know, a little less than half it looks like. The rest of you was in a hospital or an infusion suite. Yeah, so that's pretty typical. Usually you see about half the patients get it at home, half the patients get it in the infusion suite. We support all sites of care because, again, that's something that's very individualized. Some people maybe prefer it in the home, and that's the ideal place for them. Others in an infusion suite, maybe they like the social interaction that takes place there. So again, all sites are important, and we support all sites of care. What we do is actually focus more in the home setting. So that's what I'm familiar with, and that's mainly what I'll talk about. A lot of it is the same regardless. So I guess I wasn't going to keep this from being too boring, but before we talk about how IVIG works, I thought maybe we could quickly just review, you know, on a big picture level, what is it that causes muscle weakness in Myasthenia Gravis patients? And to do that, we first have to look at normal muscle function. And some of you might have seen, anybody seen this type of setup before? Yes, I'll get some head nods. So you're kind of familiar with this. And so if you look at normal muscle contraction, you have, this is representative of the end of the neuron or motor neuron, okay, which when you send when you want your muscles to contract, a signal is sent down that neuron to the end, this is called the neuromuscular junction. This is the skeletal muscle tissue. And through a complex set of events, that action potential comes down, releases acetylcholine. Acetylcholine then comes down and binds to these acetylcholine receptors, and in doing so, it triggers a set of events that leads to muscle contraction. So, the point here being that these receptors are very important. There's a lot of other proteins and things that are involved here. So some antibodies target those whenever you have with MG, but that's normal muscle function. Now in myasthenia gravis, we know it's kind of we talked about maybe having a haywired immune system or different descriptions out there, but basically has to do with antibody production. So if we think about our immune system, and we go back to remembering that, the body produces antibodies in response to a foreign pathogen or antigen, a virus or a bacteria. Say you get the flu virus, and it comes into your system, your body recognizes that as foreign, produces antibodies to fight that, and the antibodies then attack that foreign substance and help your body get rid of it. So that's how the immune system works. Well, myasthenia gravis, the problem is that although those other antibodies are present and being produced to fight infection like they're supposed to, a particular set of antibodies are produced that end up attacking, in the majority of patients, the acetylcholine receptor. I've heard of this being acetylcholine receptor antibody positive. Well, the antibody comes down and binds to these receptors. Another one is some antibodies will actually bind to proteins in the muscle, muscle-specific tyrosine kinase, which is the MuSK antibody. Other proteins have been identified there too. But the effect is that, with say on the acetylcholine receptor, it can no longer bind, so you can't get the muscle contraction. If that wasn't bad enough, these antibodies also complement or basically activate the system that's used to attack foreign pathogens, but it does that on the good muscle cells. And so you get a restructuring of this neuromuscular junction where it doesn't have these fodes and there's fewer receptors that way. End result is these antibodies, these bad antibodies, are doing damage to the core, on a cellular level, to the core proteins that need to be there for contraction to take place. So I just want to go through that to kind of so you would understand how IVIG works. So what is IVIG? So IVIG are immunoglobulins. IV stands for intravenous, so it's intravenous immunoglobulins. If it said SCIG, it's subcutaneous immunoglobulins. And immunoglobulins are just antibodies. And you've got 5 different classes of antibodies. The primary component in IVIG is IgG. That's the antibody that is kind of the workhorse of the immune system and activates this complement system that attacks the pathogens and recognizes the pathogens. But that's the main component of immunoglobulins, IV immunoglobulins. There's about 9 IV brands. 3 brands are specifically subcutaneous brands. We'll touch on those. And so what they are is they're derived from plasma pools. So some of you maybe donated plasma in the past, or you have other people who've donated plasma. You go to a plasma center, right? They collect this plasma from individuals that have come in who've been screened before they come in. And inside that plasma, there's a lot of proteins and other things that are useful in the medical community. Part of that being immune globulins. And through a series at the manufacturer, through pulling these together in a series of, they can become fractionated, and you can basically pull off the immune globulin portion and separate it, purify it, stabilize it in a solution, and that ends up becoming our brand of IVIG, which is, in the case of the liquid brands, which is mainly what's used these days, is ready to go. So then it comes to the pharmacy in a vial and to you in the home, and it's ready to be infused. One important thing about this is that although there are 9 brands, with 3 brands of subcutaneous, they're all kind of generally considered to be equally effective. However, their tolerability profiles or how the side effects they produce, and those are very much different. And so when you go back to that motto that I showed you on the logo, that does come into play here in a minute, and I'll show you a little bit about individualizing your therapy. So just to come back to this really quick, so we know that the antibody is the problem. We've got this antibody that's attacking these acetylcholine receptors, or antibodies that are attacking this muscle-specific kinase, and these are the problems. So how does IVIG work? Well, IVIG, there's multiple proposed mechanisms of action. It's not really well understood, but I'm a simple guy that wants to think about it in a simple way. And this is true. So it will bind those bad antibodies and inactivate them. Okay, so when you get all these good antibodies from 1,000 different plasma donors and they're infused in your system, these antibodies will go to work and they're going to find these antibodies, autoantibodies your body produces that attacks itself, and it's going to bind those. Not only that, it's going to speed up the body's elimination of them. So you kind of get a flood of good antibodies, and those antibodies push out the bad antibodies. Therefore, you're not having this binding to those receptor sites, and you're not having the damage to the neuromuscular junction, and normal muscle contraction, or muscle contraction can return to a normal state with good force of contraction, less muscle weakness, symptoms improve. Now, it's only temporary, it's not permanent, and that's because immune globulins only stay in our system for about 3 to 4 weeks. And so, unfortunately, it's not going to be a long-lasting effect. Generally, it's going to be effective for anywhere between 3 to 6 weeks. Now, this neuromuscular junction is also where a lot of other medications in IG work. You have your acetylcholinesterase inhibitors like Mestinon. They block acetylcholinesterase, which is in out here in this postsynaptic space, and they will actually inhibit acetylcholinesterase, which breaks down acetylcholine. So the effect of taking those, if you have more of this acetylcholine, then you can compete with this antibody for that receptor site and get more contraction. And other drugs used in myasthenia gravis, like immune suppressants, they suppress the production of antibodies throughout the system, good and bad. But in doing so, you'll have less of those bad antibodies. So most of the drugs, actually all the drugs, in some way are affecting something, this neuromuscular junction that is used in treating MG. So here's just a list of brands. You probably can't read it from back there, and it's fine because we don't need to. But this is a list of the current preparations that are approved in the United States for treating or IVIG. None of these have an indication for myasthenia gravis. It's an off-label use right now, but it is understood to be a necessary medication, and insurances do cover it under the right circumstances. But anyway, this is a list of the current products that are out there, and you'll notice every one of them has an indication out here, which is hard to read, for primary immune deficiency. And that's because that's what IVIG was really developed for. And so there's a set of people, and here's the example I like to use. Some of you will remember back to, and I don't remember the time frame, but I know I was younger, so probably early 80s, and the bubble boy. So you have somebody whose immune system is weakened, and they have to live in a bubble because this bubble was keeping all these viruses and pathogens from getting to them. Well, that's what primary immune deficiency is like. Basically, if you have primary immune deficiency, what's going on is your body cannot produce antibodies, and it's not producing the antibodies you need to do to fight infection. So in that case, IVIG is simple. You're just giving them antibodies from 10,000 different people to replace the ones they're not producing, and they have antibodies available to fight infection. It just so turned out that it was discovered that IVIG is also useful for these autoimmune disorders like myasthenia gravis, the CIDP I talked about, myositis, MMN. There's just a variety of autoimmune disorders that IVIG is also effective in. So earlier I was talking about how we can individualize your therapy to make it specific to you. One of the ways we do that is by working with your physician and selecting the right product to begin with. So if we can use what we know about these products and their formulations and choose one that looks like it should be best fitted to you. Again, everybody's different and it's not always going to be the case, but if we can come in and try to take our best guess, maybe we can head off some of those side effects before they ever happen. And so again, the manufacturers have kind of tweaked the formulations over the years to make them safer, have better side effects profiles. And although the primary component, as I said earlier, was IgG, that's the antibody that's the workhorse of the immune system, they also have different amounts of aggregates of those. They have different amounts of some of the other antibody concentrations. Stabilizers are different, additives, different levels of different types of impurities. And all these small little differences on an individual basis can have a dramatic effect for the patient. You know, some of those in one patient may not cause any problems, and another one it might cause a rash, form a breakout in a rash after their infusions. You know, and so when that happens, switching to another product that has a different stabilizer and has different types of proteins that have made it through can resolve that. You know, it may not be an issue moving forward. So again, all they're equally effective, but still very much different in a lot of ways too. So we're going to try to get the right product from the very beginning. And I'm not going to go into any detail about this because I just wanted to kind of give you the idea, but I don't want to spend any time on this really. But what I mean by product selection or trying to get you on the right product from the very beginning is we're going to look and see what else is going on with you besides myasthenia gravis. What are your other comorbidities or your other diagnoses that you may have? If you've got somebody with cardiac impairment, you know, so let's say that they have heart failure, early stage of heart failure, well, we want to give them a product that doesn't have a lot of volume. So we want to make sure we use a 10% solution, not a 5%, because they can't handle a lot of volume. There are fluid restrictions. We want to watch the sodium content. We want to choose a product with a lower level of sodium. Osmolality is I won't even go into, but it's we want to try to target something closer to the normal range, and because if we have too high of a number, it'll bring more fluid into the vascular system. Renal dysfunction, you know, a big one here. So and you can just see how it all works, but sugar content's a big one. You know, all IVIG products carry a risk of acute renal failure. You know, it's a big black box warning. Like these products are known to cause acute renal failure. When you look at the actual reported cases, 80% of those cases were sucrose stabilized products. So those are particularly bad. It's seen much less in some of the newer stabilizers. So old products like Caramune, which is sucrose stabilized, or Gemagard ST, which is glucose stabilized, the old powder, not Gemagard liquid. Gemagard liquid's good. It doesn't have sugar content. But those are particularly hard on the kidneys. You know, risk of stroke, we're going to choose things, we're going to watch our volume, we're going to choose something with the right osmolarity. Diabetes, we obviously don't want sugar. One of the stabilizers interferes with testing, in some certain types of testing strips, so we want to be careful we don't get you on that one where it interferes with your testing. So you can get the idea here. We have different risk factors, and based on those risk factors, we're going to choose a product that is has the best chance of not causing problems because of those. And this is just how we do it. And I'm not going to go into this at all, but this is all the IV brands of IG. And you can see I've got what we have listed in this table. This is a table from a good friend of mine named Tom Slice with the Immunoglobulin National Society. He's helped develop this, but you can see it gives us our different levels. You know, what is our stabilizer? It tells us our osmolarity. Basically, these different formulations, we'll look at this table and say, let's choose this product because this product looks like it could be most appropriate. Sometimes that'll be done up front from the physician. Sometimes the physician is going to be working with the pharmacy and saying, okay, help me choose a product. It all kind of depends. Majority of the physicians we work with have the pharmacy choose it. So let's talk real quickly about dosing because it's really important. The dose for IVIG in primary immune deficiency, the diagnosis I told you it was developed for, is much lower than what it is for autoimmune disorders. So what we have seen is situations where maybe the prescriber has not prescribed it very often, and they've written it for the lower dose instead of the higher dose that you would see in autoimmune disorders. And so that's something that you want to make sure you have an effective dose for the diagnosis you're treating. But for a myasthenia gravis exacerbation, this comes straight from the IGNS or Immunoglobulin National Society standards. 400 milligrams per kilogram per day for 3 to 5 days, typically once a month for 3 months, is a good dose. But altogether that comes to, if you do it for the whole 5 days, it's 2 grams per kilogram divided over 5 days. Then on patients who are being treated with it chronically, maybe they have refractory MG where they're not responding to immunosuppressants. Maybe they are contraindicated to steroids and immunosuppressants, but they're receiving IVIG chronically. There's not really a whole lot out there that's defining what the dose should be. In our experience, most physicians, they'll stick with this either 1 gram per kilogram, 2 grams per kilogram. They'll divide that over 1 to 3 days and do it typically once a month, because it only stays in your system for 3 weeks. And a lot of people have with MG who receive IVIG regularly will even see a rebound in symptoms on week 4. So what's some of the common infusion reactions? And this is something that a lot of people, when they're first introduced to IVIG, they're terrified because they've heard of these horrible infusion reactions. And this is some of them. Number 1 on the list is aseptic meningitis. And maybe some of you, anybody here had aseptic meningitis? Yes, we have one here. So from my understanding, completely miserable. Yeah, so that's what I've been told. It's like the worst feeling you can imagine. Headaches, pain. What's going on there is there's a variety of mechanisms suggested for that too, but the antibodies are increasing the pressure in the spinal cord, and it's causing inflammation there, like you may see typically with a bacterial infection. But this is not bacterial, it's from the IVIG, so it's called aseptic or sterile, basically meningitis. But it's a severe headache. A lot of it is related to, has been shown to be related to the stabilizers that's used, because just so you have it with one product doesn't mean you'll have it with another. And so when this is experienced, one of the first things you do is switch products. And there's several options that we can do there, and we can talk about. Another would be switching to a subcutaneous form. The most important thing I'm going to tell you today, and if you leave here with nothing else, these side effects, your best chance at preventing them from happening is hydration and a slow infusion rate. Okay, so hydration is king. If you can take fluids, if you want to drink before your infusions are scheduled. Most of the time with our patients, we're going to give you fluids just to be safe, because we don't want you to end up in this state where you're in a lot of pain. Now it is self-limiting, usually lasting anywhere from hours to 3 days, 4 days, and there are things you can do to treat it if it does develop. But anyway, and then the list of these other side effects here, anaphylactic reaction is extremely rare but can occur. And for that case, when our nurse goes to take care of a patient, infuse a patient, we always have an anaphylaxis kit. You'll want to make sure that if you're receiving it in the home, that nurse knows where that kit is, just in the event that you were to have an anaphylactic reaction. We have 120 patients regularly on service in our pharmacy who get IVIG every month. I've been doing it, as I said, for since 2001, so right at 17 years. I've yet to see my first case of a true anaphylactic reaction with IVIG, but it can happen, and you need to be prepared. You don't want to be that one and you not have what you need for sure. And anyway, a lot of these other reactions, the majority of them can be best prevented by adequate hydration and a slow infusion rate. So you don't want to come in, especially the first time to get IVIG, and your home health nurse say, okay, we're doing this in 2 hours, so lay back, I got another place to go. That's not the way it works. You need to start slow. Let's see let's ramp it up slowly, and then if it gets to an area that there's side effects, let's back it back down so that we know it's a rate that is tolerable for the patient. So again, prevention. I talked at the beginning about, hey, well, let's see if we can get you on the best product from the beginning for the risk factors you have. We can pre-medicate with Tylenol and Benadryl, and again, these are dark in here, bolded. Adequate hydration, slow infusion rate, the most important things you can do. In terms of treatment, again, we have slow infusion rate and administer fluids. So that's 2 things going to keep coming back that you keep seeing. There's other things we can do for certain side effects. You can add a glucocorticoid like Solumedrol. There's your dosing that we typically use in our pharmacy. This is working with your physician, of course. We don't just add this without communicating with them. A lot of times we'll have a standing order with a physician when someone comes on board. We're like, okay, doc, how do you want us to handle this? We're going to write this in the orders, and a physician will say, yeah, we like that, and we'll sign off on it. And then you may add that as a pre-medication for future infusions. Earlier, we talked about considering a brand change because the stabilizers that are used in the different brands a lot of times cause these problems on an individual level. And then if you have a complete inability to tolerate IVIG, or maybe not that, other issues where IVIG is a problem, a great option is switching to a subcutaneous form. And that's what's given under the skin. I think that's actually where we're going from here. Is I talked about the emerging role of SCIG, or subcutaneous immunoglobulins. Again, there's 3 brands that are specifically for subcutaneous: Hizentra, Hycuvia, Kevutri. 3 more of the IV brands can be given either way. That's GammaGuard, Gamunix, or GammaKid. Now, Hizentra is what the majority of our patients are on. Hizentra is currently being studied in chronic MG, which is exciting. Open label test where I think CSL is actually attempting to get an indication, which I think would be great for this community. It really needs to happen. But Hizentra is a 20%, Kevutri is a 20%. Kevutri is only available from 5 pharmacies. Unfortunately, we're not one of them. It's 5 really big pharmacies. And Hycuvia 10% is a little bit different. It has, it includes mixing in what's called hyaluronidase. It's another little vial that breaks up the connective tissue under your skin so you can infuse a larger volume, because it's only at 10%, so it's twice the volume of these other ones. And you may end up with like a little football that goes away after a few days. But some people do prefer that and are on that brand. Hizentra goes into multiple sites, and it's half the volume of Hycuvia to get the same dose. And this is just some pictures of what it looks like. I'm sure some of you are curious. That's not a grainy picture up top here, but you have somebody with a syringe that's loaded with this Hizentra, and it's pumping it in to these tubing sets, which all join together in one and connect to the end of that syringe. And these just go straight into the skin. It's a little bitty needle. I mean, it's tiny. I don't know if anybody gives themselves subcutaneous injections with insulin or those pens, Victoza, some of those pens. It's a really tiny needle that just goes 90 degrees, just goes straight into your stomach and or your thighs, and administers it under the skin that way. Now, what's the advantages of this? And that's just the different brands of Subcu. But what's the advantages? One, if you give it weekly, most of the time we talk about IVIG being every 3 weeks, every 4 weeks, maybe every 6 weeks. If you give it weekly, we keep a steady steady level of the antibodies. Okay, so and I can show you this on a graph here in a minute, but when you give it IV, you get this big high level when you give it, and then it goes down quickly over time. Well, by keeping those levels consistently where they need to be, there has been some data in some patients who report less breakthrough symptoms, like 4 weeks after their infusion with IVIG. They used to get weak, start having some return of symptoms. Well, with subcutaneous, some of these patients have said, no, I don't see that anymore because the level stays constant. No pre-medication is required because it's incredibly well tolerated. That whole list of nasty side effects we showed earlier, although they can occur, are much less likely, including aseptic meningitis, much less likely with subcutaneous than with IVIG. And then autonomy and independence. This is great. Now, this is not necessary. We have patients who get, our nurse goes and gives them an infusion once a week of Hizentra or of a Subcu product, but caregivers and the patients themselves can be taught how to administer this self-administered under the skin, so you have your own schedule. And a lot of patients really work with their physicians and really individualize this to where some just do a daily injection without doing the whole pump and stuff. Others will do it twice a week. Some will do it every week, some every other week. But you get the ability to infuse it yourself. There's a lot of training that goes into that, and the pharmacy you work with should send a nurse educator as many times as it takes for you to be comfortable. But at some point, you can see the advantages of not having to work around a infusion. And then here's a big one, right? No venous access. How many times I don't know how many people have come in here and they can't get a vein. Nurse can't get a vein. Nurse can't get a vein. Some people may have ports put in, right? Very individual decision that has to be made there because they come with their own sort of risk. Well, We can forgo all of that if you're a good candidate for subcutaneous, because we don't need a vein. It's going to go right under the skin using these infusion sets. All right, so I'm just going to, I just got the dosing here so that you can look it up later. I'm going to try to get through some of these so that we're not going past time. But the dosing is being studied right now in chronic MG. Again, as I talked about with the drug, with the subcutaneous product Hizentra. It's kind of the same dosing, except instead of getting it once a month, it's divided up over how many times you give your infusion. So if we're going to give you a 2 gram per kilogram dose every 4 weeks of IV, we're going to give you a 0.5 gram per kilogram every week. Some physicians, and it's kind of a matter of preference, will use a dosing conversion where you get a higher dose than what you was on with IVIG. That study is doing that. They're doing 120% of the dose that you were getting IVIG, and that's just because that accounts for this difference. If you look at this gray line, that's the levels you get with IVIG versus this yellow line is the ones you get with subcutaneous. And this area underneath this curve, but above this one, is represents this other 37%. So they're trying to get the total overall load the same. Whether or not that's really critical in MG, I'm not sure is as understood. This is really some good information I wanted to get to you, because one of the things we battle the most in home infusion of IVIG is problems that patients have had with other home infusion providers, or problems that physicians have had. And it can be a real challenge for me to go talk to a physician who I've never worked with before, who doesn't know me from anyone else, and I want them to understand that you can trust me with your patient. I'm going to take good care of them when they've had some of these kind of problems. I'm listing these because I want you to know they're unacceptable. Okay, so if you experience any of these issues, you should report it to your physician, report it to the pharmacy first of all, and say, hey, I don't like this, but it's not something that is appropriate at all. But so one of those would be pharmacy sent me a bill for IVIG because it wasn't covered by my insurance. I hate this one. I feel like it's the pharmacy's job. Like I said, 80% of what we do is immunoglobulin therapy. Our insurance people, that's all they work with day in and day out. They know what Blue Cross does of Florida. They know what Blue Cross of Texas does. They know what how Humana works. They know how all these different insurances work. In my opinion, it's our responsibility to give you good information about your insurance. So if we tell you, hey, it's covered, and then we end up getting denial for whatever reason, because those will happen, because insurances are famous for denying claims over small technicalities. It's our job to figure it out, not yours. You shouldn't be billed $8,000 for an IVIG infusion when you were told it was covered. There's a lot of bad information, like insurance doesn't cover it, or Medicare only covers it in a infusion suite. Well, it's true that traditional Medicare Part B only covers IVIG for Myasthenia Gravis in an infusion suite. Medicare Part D, if you do have the drug plan, which are usually pretty inexpensive plans, covers it really well for Myasthenia Gravis. And so, again, I think what I recommend doing is you get a specialty pharmacy that is working, that has their own insurance team, have them tell you what your benefits are, and that they need to work on things like, you know, what are co-pays and how much of it is covered, and take that burden off of you. Another really bad, when nurse starts infusion, leaves, and comes back at the end of the infusion. Not acceptable. If something goes wrong, obviously, what are you supposed to do? You know, just unhook yourself, give yourself CPR, you know. It doesn't make a lot of sense. Nurse will only infuse the IVIG, but not some of their other therapies. You know, not the hydration that goes with it. It's just silly. It's all based on business and time and making money, and again, I don't think it's appropriate at all. Nurse will stay for a maximum of 4 hours because that's all your insurance covers. You know, yeah, that really probably stinks that the insurance only covers 4 hours, and maybe the right effort could be made into increasing that. But I don't believe that as clinicians, we should treat someone based on what their insurance covers. I mean, my favorite saying is, we're going to do it right or we're not going to do it at all, right? And doing it right doesn't mean I got to hurry up and get you done to get to the next person. We've heard instances where nurse trains the patient on how to infuse it through their port and told, hey, if you have any problems, call 911. Nurse tells patients they have to infuse fast because they have certain, that's a common one, they have other patients to see. And so we talked about earlier, the problem being, the best way to prevent those side effects was slowing the rate and hydration, right? Well, if you're coming in and you're slamming it in 2 or 3 hours on somebody who can't tolerate that, you're going to have those problems, and you shouldn't be expected to just suffer for 2 or 3 days after an infusion because a nurse had other patients to see. Yeah, and again, aseptic meningitis is like the one that's known very commonly that patients are terrified of with IVIG, and we see it so rarely. And I know why. It's because patients are adequately hydrated, we give them hydration, we infuse it slow. That's just like I said, a very important thing. Nurses fighting veins, which I'm kind of sympathetic to that, but you need a nurse who's that seems to be more of an art than anything from what I can tell. Lack of follow-up if there are reactions. Your pharmacist should be working with you closely. Different nurses are seeing, and then lack of things like washing hands. All of that is inappropriate at all. I'll quickly talk about Solaris because I did say I would talk about some of the newer therapeutic options. I will be honest, I'm still learning a lot about this drug. We have right now 3 orders that we picked up last week for this product, and we're still working on getting the first one set up. So I have not actually had any of my nurses infuse this yet. I've just begun to start kind of researching what it is and how it works. And here's what I can tell you so far. And I did read through it was a reframe trial, but whatever trial it was that got the approval and read some things there. But it's FDA approved for patients who are positive for the acetylcholine receptor antibody. It's infused over 35 minutes, so that's really kind of nice benefit, I would say. It's not a terrible infusion. It blocks a key step of the complement cascade. I thought this was pretty interesting. So when we talked about that, remember the very boring slide in the beginning with the neuromuscular junction? And we talked about how the antibody can bind the acetylcholine receptor, and not only that, it activates the system that attacks that just like it was a foreign substance. Well, this drug works within that complement cascade. And so in doing so, if it can inhibit that complement right there, it can prevent the damage taking place to the structure of that junction that ultimately lowers the receptor sites. So I thought that was pretty interesting. Side effects are headache, dizziness, fever, kind of standard type side effects, and from what I understand, fairly well tolerated. And I haven't had any personal experience with that yet. But the dosing that I've been able to find, 900 milligrams every week for the first 4 weeks, then 1,200 milligrams at week 5, and 1,200 milligrams every 2 weeks thereafter. It does have a black box warning for meningococcal infection because you're attacking complement. Complement's used to fight infection, just like you have similar with other immune suppressants. You have similar problems with the risk of infection, but there is a risk there, and they have a recommendation, unless for some reason it's inappropriate, to get a meningococcal vaccine 2 weeks prior to the first dose. And then if you end up getting plasma exchange while on it, you'll need a supplement dose because part of this is removed from some of the drug levels will be reduced with a plasma exchange. And then finally, since I'm only going over, y'all ready for me to sit down? I just heard the giggle of, why don't you sit down back there? I'm sorry, because I feel like I've gone over, but I will make this quick. So coping with insurance denials for IG therapy. I wish it wasn't true, but probably 30% of my time as a pharmacist is spent on insurance authorizations. It's just the reality that's there. And here's some basic advice I'm going to give you. One, I've already said, don't go at it alone, okay? We have Michelle Vogel, I mentioned earlier, is one of our patient advocates. We bring her in anytime we have issues getting something approved. So when it gets bad and they should be covering this, but they're not, she's someone we kind of bring in as, and I call her my bulldog. I don't know if that's a compliment or not, but to me it is. She will get on them and say, hey, this patient needs their therapy right away. What's the holdup? And she's really gifted at doing that. But again, use the specialty pharmacy's insurance team and ask for a case manager to be assigned to you. This is, if you find a case manager at the insurance company, to me, in my opinion, it seems like it gives you an advocate within the insurance company in a lot of ways. They're usually a nurse, they understand your condition. It's not, it can be a real advantage if you can have a case manager assigned to you that the pharmacy can work with. And then the main thing is prevent the denial from up front. So we're going to make sure we understand the coverage criteria. In the back of this book, this is a little book everybody got that we put together for MG patients and what you should know with IVIG. There is a page towards the back of this book that shows you, there it is right there, page 15, that shows you the kind of, they're all a little bit different, but the usual coverage criteria. What we need to do is we want to show the insurance before the authorization is given, as we're applying for that authorization. We want to show the insurance why you meet their coverage criteria. If we can do that, we'll prevent the denial to begin with, get your therapy sooner. We don't have the problems of the appeal. I mentioned patient advocate earlier. To me, this is huge. At CSI, you get assigned a patient advocate for every patient, and they'll help with things like insurance, copay assistance. Copay assistance programs are out there. This is expensive therapy. Ask your special pharmacy what's available when they're allowed to. A lot of times we'll have our own plans of copay assistance. And then the appeals process, again, we want to try to get from getting there, but we'll try to before this point. But when we get to this point, I'm getting involved. I'm writing a letter saying, look, this is your coverage criteria. This is where they qualify. Here's all the clinicals. And we'll do that a lot of times beforehand to try to prevent that denial in the first place. So that is what I have for you. And if you have any questions or answers, if I have any questions, I'll ask you to get answers. And I'm sure there's a lot I can learn from you. But if you have any questions, I'll be available afterwards. Just come see me. I've got Michelle's business cards to hand out to you if you want to talk to her about anything specifically. I've got my cards. And we'd love to hear from you, and I'd love to help you any way I can. Thank you.
Well, we just wanted to, we know we went over time today, but we had some wonderful speakers, and we're just so grateful for Tammy and for Andy who came and gave their time today. Thank you guys so much. It was so wonderful. If you have any questions for them or for what they can give you for emotional and mental health support, please, please, please come see them afterwards. Their cards are on the tables as well. And we'll send out emails and updates for what any kind of resources that you all are going to do and offer for caregivers. We are going to bring them back in October if everything collides correctly. And what we're going to do, we're going to kind of break down into different groups, specifically for patients and then for caregivers. So I've found a lot of times, and I'm sure you found a lot, is patients feel a very specific set of ways and they don't want to burden their caregiver. And the caregiver feels a very specific way and they don't want to burden, the person they're caring for. And so I think we just want to kind of create an environment where you can be free and open and honest and get some support specifically for where you're at and what you need. So we're very excited about seeing them again. I want to thank James for sponsoring our lunch and this meeting and doing such a wonderful job and flying all the way from Texas for us. Thank you so much, James. And I'll leave it with the big cheese right here.
What? Big cheese? Swiss, Munster, which one is it? Thank you again, James. Thank you, Tammy. And we were talking about how long we've known you, and we were all kids 28 years ago. So that's been a long time. Her and her husband, Stu, they're special people. And I also want to say what James talked about. Counseling is important. We've had our family go through counseling, and I think the world thinks that if you go through counseling, you're weak. You're not. The person who admits that they need the help, they're a strong person. So go use that help. And for what Jane said about the IVIG treatment, it's kind of like Texas barbecue, slow and low, right?
That's it.
Absolutely. I want to remind you before you go, again, the posters, if you want to take it to your doctor or ophthalmologist about NG and the quarterly report. And please pick up these things from James, because James doesn't want to take them back to Texas. So for those who came in late, it folds up and you unzip it, and it's a nice little bag, carry groceries or whatever in it. Earphone, portable earphone, and this is you put in your freezer and you cool off with it. So again, thank you, James, for everything you've done. And so for our new people here, we do not meet during the summertime.